All right, good afternoon. This is the thesis defense for Micah Hébert, and she is going to be sharing the project that she has spent the last 2 years doing. Some housekeeping procedures. She is going to go through her presentation, take about 20-30 minutes. After she is finished, the presentation will be open for questions from the public. That includes the people in this room, as well as those of you on Zoom. We'll ask that the committee holds their questions until the public has had a chance to ask their questions. When the public has no more questions, at that time, we will ask the public to leave, and the committee will ask questions of Micah and discuss her thesis in private. This is being recorded, so choose your words carefully because it's going on YouTube for posterity. I think that handles all the housekeeping aspects. At this time, I'll hand it over to her mentor, Dr. Deanna Schmidt.
Thank you very much. I get the pleasure today of introducing Micah, and I had to make some notes. So Micah did her undergraduate here at CSUSM in human development, and then she decided to come and do a master's in kinesiology, for which I am thankful for one. Glad she decided to come spend 2 years doing a science study with us. She was also formerly a volleyball player for CSUSM. So about 15 months ago, maybe a little bit more than that, I met Micah, and Micah had an interest in anterior cruciate ligament injuries. Harkening back to my PhD, I did some post-surgery work in the lower limb, and so we put our minds together and looked at what we could measure in the lab and what we could look into for ACL, and we came up with this project together. So I think you will find it exciting. We did. I'm going to say Micah once described these results as spicy. That is my favorite word for science results. So what else do I want to say? I just want to say a little bit about Micah. Having her as a grad student has been an absolute pleasure. I know we say these words a lot describing people, but she is really genuine. She is dependable. She is reliable. I mean, she's just always there. She is super hardworking, and she has done a lot of work, especially, I mean, the last few months. Yeah. She's measured, well, the whole time, but she measured 42 participants, and she scheduled them all and measured them all. Did all the results, and so it really has been an exciting time. I just also want to tell you, Micah is always willing to put the work in, even when I scheduled a meeting for us on Cesar Chavez Day and the university was closed, and I got here and went, oh my goodness, the outside doors are locked. Micah came anyway, and we sat in my office by the window light only because the lights wouldn't turn on, and we worked on our thesis. So even when the campus was closed and I didn't realize it, she was here, and that just says a lot about her constant hard work and the amount of effort that she's put in this entire time. And then I just want to say, today really is about celebrating the accomplishment of her master's thesis work, and I hope you enjoy hearing what all she discovered during this project.
Thank you. First and foremost, thank you to everyone that attended today. It means a lot to me. This is my thesis defense presentation. So the title of my thesis is Comparison of Lower Limb Anthropometry and Balanceability After Anterior Cruciate Ligament Reconstruction. This is the table of contents. We're going to start off with background information and get into the introduction, go over the purpose of the study, talk about the methods, the data analysis, the results, get into a discussion, go over the acknowledgement, show my references, and allow for questions. Quick background info: anterior cruciate ligament or ACL injuries are the most common knee ligament injury with about 100,000 to 250,000 occurring every year in America. Factors that contribute to tearing an ACL or activity level, sports and activities played, sex, family predisposition, and age. Females, especially female soccer players, are more prone than males to ACL injury. Quick introduction: ACL reconstruction can cause quadricep atrophy, and muscle weakness. ACL surgery can cause a decrease in balance, specifically when balancing on foam. Also, ACL surgery can possibly cause asymmetry of the muscle volume between lower limbs. And MRI demonstrated that atrophy and a difference of 20% volume and muscle in the thigh and shin after ACL surgery as well. So the purpose of this study, well, specifically the goals of this research were to compare the lower limb of persons who had ACL injury for differences in size, muscle mass, body water, and the ability to balance on one leg. We also compared dominant and non-dominant lower limbs of control participants, and we expected that there would be a greater difference between lower limbs in those who have ACL reconstruction and those who have not regarding muscle mass and balance ability. And we created these goals based on previous research that we looked into before starting my thesis project. Our hypotheses were that we hypothesized that there would be a difference in skeletal muscle mass, thigh circumference, body water when comparing the surgical repaired ACL lower limb to the lower limb that did not have surgery. We also hypothesized that there would be a difference in the amount of postural sway during single limb standing when comparing the lower limb that had ACL reconstruction surgery to the lower limb that did not have ACL reconstruction surgery. So we're going to get into our methods, specifically like the type of participants we had. So for ACL participants, we had 12 total. We had 8 female, 4 male. The average age for our ACL participants was 24.2. Average height was 171.6 centimeters. Average mass was 80.2 kilograms. And the plus or minus and the number following is standard deviation for those categories. For our controls, we had 30 total. We had 18 female, 12 male. Average age was 24.5. Average height was 168.8 centimeters. Average mass was 72 flat. And again, the plus or minus and the number following is the standard deviation for those categories. This is a chart giving a more in-depth look of our ACL participants. We kept track of sex, how old they were, which lower limb they injured, if they tore their meniscus and had it repaired during their ACL reconstruction, the type of graft that they used, year of their surgery or injury, and time since surgery or injury. And that last column was calculated by the time that they had surgery, or the year that they were in the study subtracted by the year that they had their surgery. More into our methods. All participants completed a health history questionnaire at the time of the study. We ended up not excluding any of our participants. The measurements that we took were segmental skeletal lean muscle mass, body water, thigh circumference, and postural sway balance. So for in-body testing, we collected data for body mass, percent body fat, skeletal muscle mass, segmental skeletal lean muscle mass in each lower limb, and we collected the ratio of extracellular body water to total body water per lower limb. And this is just an example of what participants look like when they're doing the in-body testing. After in-body, we did postural sway testing. We used the vertic force plates. We did 4 30-second trials. 2 trials were on a firm surface, 2 trials were on a foam surface. For controls, we tested the dominant lower limb and non-dominant lower limb in each condition. For ACL, we tested the surgical lower limb and non-surgical lower limb in each condition. Every participant was given clear instructions on what to do and how to stand on the force plates. They were also given a practice trial. The order of the trials were randomized from participant to participant, and we gave at least 30 seconds rest in between each trial. And this is just an example of the conditions that we were testing our participants in. We also did thigh circumference. We measured bilaterally, proximal to the superior pole of the patella with a tape measure. We measured 10.2 centimeters up from the kneecap, and then we measured 15.2 centimeters up from the kneecap. And this is just a picture showing roughly the areas where we measured. That is not to scale, and all measurements were taken by the same researcher. So for data analysis, we use Microsoft Excel and SPSS software. We calculated averages and standard deviations. We used paired t-tests to compare the dominant lower limb in control participants to the non-dominant lower limb in control participants. And then we also used the same t-test to compare surgical to non-surgical lower limbs in our ACL participants. We then used a mixed factorial ANOVA with planned comparisons to analyze our postural sway data within the lower limbs and between both participant groups. Then we used Bonferroni-Pocost test after, and the significance level we used was 0.05. So now we're going to get into our results. We started off with segmental lean analysis, then body water, then thigh circumference, and then we'll end with postural sway. So we're going to talk specifically about the ACL participants first. For segmental lean analysis, we found no significant difference in lean muscle mass between the surgical leg and non-surgical leg. We found that the average skeletal muscle mass for our ACL participants was 32.76 kilograms with a standard deviation of 5.57 kilograms. Average percent body fat were 27.28% with a standard deviation of 8.37%. On average, ACL participants had more muscle mass than controls, which was surprising. On average, ACL participants had more consistent data in comparison to the variability of the data of the control participants, which was an interesting find as well. This is a graph of the ACL participants' lean muscle mass. It has lean mass of the surgical limb, lean mass of the non-surgical limb, and the difference of mass between the limbs. The difference of mass was calculated from non-surgical lower limb minus surgical lower limb. And if there is a positive number, that indicates the non-surgical leg had more muscle mass. If there's a negative number, then the dominant lower leg had more muscle mass. It's worth noting that on average, our participants weren't very different in between their legs for lean muscle mass. The difference was on average 0.05, which is pretty much almost nothing. So that's what we calculated for that. I would like to talk a little bit about leg dominance in regards to segmental lean analysis for our ACL participants. We saw that leg dominance did play a role in lean muscle mass for the lower limbs of people who had ACL surgery. If an ACL participant had surgery on their dominant lower limb, then more muscle mass was maintained on the surgical lower limb versus the non-surgical lower limb. If an ACL participant had surgery on their non-dominant lower limb, then the dominant leg still had more muscle mass. There was only 2 ACL participants that didn't follow this trend. One had surgery on their dominant lower limb and ended up with more lean muscle mass on the non-dominant lower limb. One was the most recent ACL participant we had, or the most recent ACL participant that had reconstruction surgery. And the other one had just injured their ACL and didn't have surgery. Now we'll talk about our control participants. The dominant leg for our control participants had significantly more lean muscle mass than the non-dominant lower limb. That p-value for that was 0.005. On average, the skeletal muscle mass for control participants was 30.26 kilograms with a standard deviation of 9.77 kilograms. On average, percent body fat were 25.65% with a standard deviation of 7.47%. This is a chart of lean muscle mass for the dominant leg and non-dominant leg, mass overall, and segmental muscle mass and percent body fat. We had marked the significant difference of the non-dominant leg. It had significantly less skeletal lean muscle mass than the dominant leg. So we marked that with an asterisk. And the mean is the regular number, standard deviation is in the parentheses. So in regards to our hypothesis, the data that we collected did not support it. The p-value for specifically segmental lean analysis was 0.248. In our control participants, the dominant lower limb consistently had more muscle mass than the non-dominant lower limb, which was contrary to our expectations. We were expecting some kind of difference in our ACL participants, but that wasn't the case. Now we'll talk about thigh circumference. In our ACL participants, there was no significant difference at the 10.2 centimeter mark or at the 15.2 centimeter mark. We also included the averages for the surgical lower limb and the non-surgical lower limb for both of these marks. We found that there was a main effect between the ACL and control participants via ANOVA. That F value was 144.287. That P value was 0.001. And we found that the main effect between the ACL and control participants was that the control participants did have significant difference at the 10.2 centimeter mark in their dominant lower limb compared to the non-dominant lower limb, but they did not have significant difference at the 15.2 centimeter mark in the dominant lower limb compared to the non-dominant lower limb. And we also included the averages for those measurements for both the 10.2 centimeter mark and 15.2 centimeter mark. So for our hypothesis, data that we collected did not support it. We had expected that ACL would have more difference in their lower limbs, but it turned out that our controls had more difference in their lower limbs in regards to thigh circumference. For body water, for ACL participants, there's no significant difference in body water. For our control participants, though, there was significant difference in lower limb body water based on leg dominance. The dominant lower limb was consistently shown to have more body water than the non-dominant lower limb in our control participants. And for our hypothesis, again, the data did not support what we had previously thought was going to happen. We thought there was going to be more body water in our ACL participants than our controls, but that was not the case. Lastly, we'll talk about postural sway. There was no significant difference for either group or any surface. Specifically for the foam trial, there was no significant difference in forward movement, backward movement, to the right or to the left. These are tables for the control participants with averages of their direction based on leg and what surface they tested on. Same chart for ACL participants with what leg they tested on and what surface they were tested on as well. And again, our data did not support our hypothesis that postural sway would be more different in ACL participants than controls. Now we're going to get into our discussion. Just to recap our goals, we wanted to compare the surgical lower limbs and non-surgical lower limbs for differences in segmental lean mass, body water, size, and ability to balance on one leg. We compared persons with ACL surgery or injury to a control group. We expected that the ACL participants would be more asymmetrical than the control participants, but our data did not support this. So I want to talk about similar research. One of the papers that helped shape our study was Norte et al. They looked at differences in lower limb muscle mass with persons who had ACL reconstruction surgery. They used MRI to assess muscle mass, and we used bioelectric impedance. Their results demonstrated that thigh muscles were more than 15% smaller on the ACL injured limb pre-surgery and were 20% smaller than the muscles on the uninjured limb post-operatively. We found that the lower limbs in our study with our ACL participants, on average, were only 0.5% smaller than the uninjured limb. Differences in average post-op for ACL participants for Norte et al. Their participants were only 7.4 months post-op. Ours averaged about 60 months post-op, so that could have an effect on the results that we got compared to theirs. Another paper I'd like to discuss is Schmidt and Bell. Both our research and their research looked at postural sway in persons who had ACL reconstruction surgery. In their research, they found that people who had ACL reconstruction did worse on single lower limb balance testing on foam surface rather than controls. They reported a non-overlapping 95% confidence intervals. We found that there was no difference in balance between ACL participants and control on either firm or foam surface. Average time after surgery for Schmidt and Bell was about 3 years. For ours, on average, it was about 5. And again, time after surgery could contribute to the differences in study results. One final paper I'd like to talk about is Stuhr et al. 2021. They found that people who had ACL reconstruction on their non-dominant lower limb had lower quadricep strength at 6 months post-operatively compared to those who had ACL reconstruction on their dominant lower limb at around the same time. In our study, we found that if ACL participants had surgery on their dominant lower limb, they had more segmental lean mass in their surgical lower limb versus non-surgical lower limb. And if the ACL participant had surgery on their non-dominant lower limb, then the dominant lower limb still had more muscle mass. Now, they were talking specifically about strength. We were talking about muscle mass. So we thought that if there's more muscle mass, then there's more strength. If there's less muscle mass, then there's less strength. So that's how we decided to tie those two papers together. some limitations we had in the study. We did not make any comparisons based on sex of the participants in the study. However, our data did show that leg dominance may contribute more to comparisons in segmental lean mass and circumference on average between lower limbs and sex. Two of our ACL participants had injuries but not surgery. We looked to see if we removed their data would it have an effect on our results, and it didn't. We had the same results that we did with them in the study. Third, we did not have the number of ACL participants to separate them out into subgroups and make comparisons within the ACL group based on type of like reconstruction graph or type of amount of rehabilitation. Fourth, it should be mentioned in our study that measurement of lower limb muscle mass was computed by bioelectrical impedance, and therefore the lean muscle mass of the lower limb included the hip area as well. In conclusion, leg dominance played a role in lower limb segmental lean muscle mass in body water for control participants. We found that there was a significant difference in thigh circumference at the 10.2 centimeter mark for controls. There is no significant difference for thigh circumference in ACL participants at either of the marks that we measured. There was no significant difference in postural sway in either our ACL participants or our control participants. I'd like to take the time to acknowledge my advisor, Dr. Deanna Schmidt. And I would like to thank Dr. Paul Stuhr and Dr. Mike Schubert for serving on my thesis committee. I would also like to thank Dr. Dill for her help with driven and data analysis. I'd like to give a special thank you to Josie and Bryn for assistance in the research project. These are my references I used for my presentation. And thank you to everyone who came to my thesis defense. It really means a lot to me.
At this time, the presentation is open for questions.
Yeah, I have a question. The ACL group, all of them had physical rehabilitation programs?
Yes.
Okay.
So this is what we kept track of, what type of prehab, like any type of rehab before surgery and after surgery. We kept track of it in this chart right here. We again kept track of their lower limb that was injured, sports or activities that were done, any prehab if they did any, and what their rehab looked like.
Okay. Let's see, the control group, did they have any particular exercise program that may have been considered similar to the rehab program?
We did record what our control groups did as well. I don't have a chart for that in my presentation, but it was, some controls did have a strict regimen they stuck to, some controls just did nothing and they just were just at school and did that. So like there was like a lot of variability in between what they were doing just out and about, but I don't have a chart to show that in my presentation. My apologies.
Okay. Do you think that the rehab program may have helped balance the strength and control between the surgical and non-surgical limbs for the ACL people?
I feel like that would contribute, since all of the ACL participants we collected data from all did some form of PT, either in a clinic or rehab with their athletic trainer, or just did something on their own. I feel like that definitely contributed to them being more symmetrical than our control participants. But
All right,
to what extent, I can't say.
Oh, okay, thank you.
No problem.
I have a question.
Yes.
Do you have any speculation as why the ACL participants have more skeletal muscle mass than the non-ACL participants?
I was suspecting that, I think it had something to do with their rehab again. Maybe they're more meticulous with their rehab since they know that one leg is injured or has surgery, so they need to be careful, make sure they are strict training to make sure they don't lose any more muscle mass that they had at the time of surgery. So I think they're more maybe intentional with their rehab, so that's what contribute to them being more even than our controls.
Congratulations,
Thank
nice
you.
job. So my question, I wasn't here when you came up with your project and designed it. Was there a rationale or why did you not actually measure strength? Can you comment if you had, do you think would your findings change?
I think that would have been very interesting to look at. I originally was thinking of doing more of a qualitative study. I was just gonna talk to ACL participants and see how they felt their ACL recovery went. Because yes, your doctor can clear you, but do you truly feel the same? And I was gonna see if we had enough participants. I wanted to look at if maybe different graph type use had anything to do with that, but I wasn't able to go in that direction, but I am happy with what I was able to achieve. But I would love to do a strength study on ACL participants as well.
So, do you have any data on how these participants actually injured their ACLs? Was it
When
a sporting event?
we just asked when they tore their ACL and what they were doing at the time of like their rehab, we didn't specifically say what sport they were doing, or what activity they were doing that caused them to tear their ACL. Like maybe they would have talked about it in explaining it to me, but I didn't record that data.
Could the differences in skeletal muscle mass simply be driven by the fact that you are recruiting potential athletes or former athletes versus controls that may not even participate in athletics at all?
Yeah, I think that might have had something to contribute to it as well. Overall, the majority of my participants are all from like the kines department, so all of them were fairly active. So I don't know to what effect that having potential athletes or formal athletes in the ACL group had to the control group, because everyone was pretty like fairly active. I think I had maybe 1 or 2 participants that really didn't do much in the controls.
How did you measure limb dominance?
We asked them verbally, like, what is your dominant leg? And if they had trouble answering that, we would ask them, what leg would you kick a soccer ball with? And we wrote whatever leg they said. Because they're used to being asked, like, oh, what's your dominant hand? Maybe not your dominant leg. So I use that question to help them get to, okay, what is my dominant leg? So we just, what they verbally told us.
Sorry if I missed this. Did you state that their dominant limb was primarily their injured ACL limb?
Yes, I do. I just need to find the chart. Yes, so we reported what they listed their dominant lower limb as and what limb they had their surgery on. So all of our participants were right leg dominant, and we did have a few participants that had surgery on their left limb and a few that had on their right.
Okay, so it's nearly half and half. Okay, because I was wondering if particularly why they had similar muscle mass in both limbs was because their dominant limb was injured and because the other limb would catch up.
Can you go back to the slide where you had their demographics for post-surgery, how many years post-surgery they were? Please. Sorry, at the very beginning of your presentation.
It was.
So
Yes.
And so one of the things that you brought up several times in your discussion and how your data did or did not mimic other people's data was duration past injury or surgery. Is there a way that you can use your current data to actually get to that, to see if there actually is a duration issue?
So looking at our data, you want to know if we're able to see if duration is like a factor?
Yeah.
I believe that would require looking into more if that's been looked at in previous research and then formulating like another project maybe surrounding that. I'm not quite sure how I would use the data that we have now to answer that question.
But don't you have a spread of data there from a half a year post-injury to 10 years post-injury? So couldn't you do some sort of statistical analysis to figure that out?
I feel like we could. I just don't know what type of statistical analysis you would do off the top of my head.
Thanks.
No problem.
I'm gonna ask another question.
Yes.
So did you look at, like, it looks to me like that number 9, that 44-year-old male who's 10 years post-surgery could potentially be an outlier for multiple reasons. Did you look at, like, is that driving some of the data?
Like if we were to remove him, how the data would look. I don't believe we looked at that, but I do want to see what that looks like if we do remove him. Because yeah, he was our furthest along for time since surgery. So I feel like that might have some sort of impact on our data.
I'm sorry, I
It's
like
okay.
like those questions. So can you explain methods to me, like why did you measure that spot on the thigh, and then how did you measure postural sway? Like, I'm kind of fascinated by the lab, sorry.
So we decided to measure thigh circumference as well, because that's one of the measurements that my physical therapist used to test how well I'm going in my rehab regimen. And she told me that they do 4 inches above the kneecap and 6 inches above the kneecap. That's like their standard practice that they do. So I thought to incorporate that into the study. And for postural sway, the way that we measured how far the center of pressure moved, we used the Vertec force plates, and the data that they give us, it shoots out different columns of how much that person moved in each of the directions we looked at. From there, we calculated the difference in like forward, back, left, right, and then we charted that. We were able to go to the chart that I had in here.
So that picture you showed, you're not looking at it, it's the plate that actually gives you the data.
Oh,
Yeah.
The data is collected from the force plates and it's shot into their program, and then we grab the data from there. I know that in one of my studies that I used for this, my thesis project, they had used the BESS system, BESS, and they used visual cues to determine how well a person was balancing on one leg and whatever surface they were using, but I decided not to use that and just to use the numbers that we got from the Vertec force plate.
Things you learn in a day, thank you.
You're welcome.
I enjoy learning this.
So let's go back to that other slide again where I was looking at. And so it's quite easy to identify subjects that actually have gone through surgery, which you have 10 of, but you do have these 2 partial tears. How did you actually determine that that was the true diagnosis? Did they have MRIs that they showed you, or was that just their verbal?
That's what they verbally told us, yeah, and they told us based on like whatever or MRIs that they did with their doctors, but we didn't have like physical proof that they did in fact partially tear their ACL. Everything that we've collected from this table was all verbal.
I would push back on that, and I don't know if that would be, I don't know if I would keep those in the analyses myself.
Okay, since there's like no definite way to like
No way
confirm.
Obviously with an ACL reconstruction, it's very easy to
Yeah.
confirm, as you know, but the partial tears, it could be hearsay.
Mhm,
So the physician may have said, I think you have a partial tear, and that was basically, or they may have an MRI, maybe in different degrees of tears too, so I don't think that data should be, that's my personal opinion, should be
Yeah.
incorporated into your analysis.
Okay, thank you.
Oh, yeah.
Oh, okay.
Curious about that postural sway.
Yes.
Is there a particular mechanism that's thought to be behind possible differences in sway? So is it strength differences? Is it differences in receptors? Or what is thought to be the mechanism?
Off of the top of my head, just from my background, I did a little bit of like physical therapy aid work, and that also kind of shaped why I decided to do my thesis on what I did my thesis on. One of the head physical therapists that I worked with, she said that for a lot of people, there's either the ankle takes in control when they're trying to balance, or the knee/quad takes into control when they're trying to balance. So for some people, there's more movement in the ankle trying to stabilize, and for some people, they tend to lock up their quad more to try to balance. So it's mostly based off what my physical therapist that I work with told me. She said that she's noticed in her years that people will either move the ankle to stabilize or flex the knee really hard and flex the quad really hard to stabilize. So I feel like for our participants, that could have played a part in why they were balancing the way that they were, or why they made the movements that they did.
Other questions from the public or those on Zoom?
I just have one question, going back to, Dr. App asking if participant 9 was a possible outlier. Can you just go to the slide that has the ACL muscle mouse? I just need to look. So subject 9 there. So that is the participant that's farthest from surgery. Just something for us to look at, Micah, as far as whether their data is actually an outlier or not. But I don't think their data was outside of 2 standard deviations of the rest of the group. But we can look at that.
So one more question. So the take home message is asymmetry good or is asymmetry bad?
Yeah, that's what I was like. We sat down and we analyzed everything. We were like, yeah, the ACL participants are almost perfect, and our controls are like asymmetrical, like very asymmetrical. And I was like, okay, well, there goes my whole thesis. So, it kind of makes me want to do like more research on it, because I don't think there's very many papers just looking at healthy adults to see if they are asymmetrical or not. It's usually when there's an injury or there's a surgery where you start looking at differences. But I think it's really worth looking into just normal healthy population to see if there's like, if it really is an issue. Because I would have never thought that the control participants were going to be more asymmetrical than ACL participants.
But doesn't the train of thought in physical therapy is that asymmetry is a bad thing,
Yeah,
correct?
yeah.
Yeah, but that it may just be a normal thing instead of a bad thing.
Yeah, like maybe like you're just using your dominant leg more, and like, you know, you're living a healthy life, you don't feel any pain, so you're not thinking to look into it.
Any other questions before we meet with Micah as a committee? Chat, going once, going twice. All right, this defense is closed, so at this time, we'll ask the public to step out. And the committee will now meet with Micah individually. Thank you for coming.
Thank you. Thanks for coming. Super.